Thank you, Dr. Masi Korir. And the discussion was very lively. We are going to have a presenter, and thereafter we are going to have another panel discussion before we break for lunch. I will call upon Andrew Pound, Managing Director, HPI. HPI is Health Professionals International. His job is career advisory and recruitment. He has 30 years experience in emerging markets. What he's going to talk is about international labor markets. So, Mr. Andrew, can you come forward? As he comes, can you give him a kilo? Okay.
Thank you very much. I think I need my glasses here. Distinguished guests, ladies and gentlemen, thank you very much for this opportunity to speak. Firstly, let me say that I'm here courtesy of one of the unions, and if anything that I say raises some questions in your mind, you have any issues you want to address, please channel them through your respective professional union, and that will be a way to reach me, okay? In a nutshell, this is a very complicated sector. Healthcare is huge, and people have been doing this for a long period of time, and there's a lot of information out there. So I'm going to try and necessarily compress things into maybe 5 minutes. It's going to be very, very telegraphic, but there will be a lot of information that can be followed up after the event with your respective union. So please do. So in a nutshell, you have talent all over the world, equally distributed. Kenyans are as capable as Brits, as Australians, as the Chinese. But the thing is, opportunity is not equally distributed, okay? And in high-income countries, they've been spending money on healthcare for a long period of time, in fact, twice as much as low and middle-income countries. And as a result of that demand, the healthcare systems in those high-income countries are huge, and they are the net importers of talent, as well as all sorts of health and healthcare products and services. So where is that talent coming from? You've got basically talent coming from low and middle income countries, specifically India and the Philippines, but it's a long tail, okay? And why does the talent come from those countries? Because governments in those countries have taken public policy decisions to get organized and to use their collective power. In India, effectively, they produce lots of talent. I'm not going to give you the numbers right now. We're talking millions. We have some information. We can certainly share that with you. In the Philippines, in India, you've got more than 1 million places in diploma nurses, just an example, and more than 1 million places for nurses doing degrees. So that's the competition that Kenyans are up against. Secondly, in the Philippines, they've got a slightly different model. They don't produce the volume, they add value. So there's a government entity that is that regulates the sector, the overseas recruitment sector. It protects the rights of workers, and it arranges for administration support to make that happen. Okay, so again, those are two models that you might usefully take a leaf out of the book of. Okay, so in a nutshell, that's the demand is over there in the high income countries historically, and you've got supply from the low to middle income countries. Now, what has happened is that you've had this COVID shock that has thrown, to make light of the situation, possibly a spanner in the works. Okay, that's caused huge disruption globally. It's exposed lots of shortcomings, including in the recruitment sector. So as a consequence of that, you've had these high-income countries seriously analyze what's gone on and how should they fix things. And it's been recognized there that the pendulum has swung too far, that they've been taking too much and haven't been giving enough back. And so there is this recognition that they need to develop much bigger pipelines of domestic talent. Okay, now that's not going to happen overnight. And so for at least the medium term, these high-income countries are going to be recruiting talent from overseas. That ain't going to change, okay? But over the medium to long term, the situation will change, and there will be more equilibrium, and you will find a situation whereby international recruitment is much more of a matter of cultural exchange and far less a problem of brain drain, okay? So give it time. But right now, there is a demand for talent, and there are hundreds of thousands, millions of jobs overseas, okay? Now, some of these low to middle income countries have almost had like a knee-jerk reaction, and things have happened. So you've seen stuff happening, for example, in Zimbabwe, where the generals have simply put the anchors down and stopped the nursing council issuing certificates that you need. In Kenya, for example, the government has changed its status from green to amber. Okay, so as a result of this sort of reaction, the demand hasn't changed. So the high-income countries are simply taking the next taxi from the rank, okay? There are no jobs going unfilled in these countries because Kenya has an amber status, okay? The jobs are still being filled by people from other countries. So it's a question of what do you do? And I would suggest that you play to your strengths. Be competitive about this. Where is your comparative advantage versus other source countries compared to India, to the Philippines, and all the other long list? And I would suggest that there are 4 or 5 areas you might want to look at. Firstly, you might want to preserve the amber status as a competitive bulwark. Okay, so in the same way that you've got recruitment from the Philippines, which is the subject to a government-to-government arrangement, it is not a free-for-all private sector green list situation. You could usefully use the same method here if you, as a collective group of healthcare unions, organize to speak with one voice, okay, which is on the advertising. Use your collective bargaining power to influence government policy. That, I think, is something that will work in this country. There's another slogan behind me: all cadres. Okay. Now, health and social care is not just health; it's also social care. So, for example, I don't see any social workers represented here. But there are loads of jobs for social workers. There are loads of jobs for speech therapists, all the other disciplines, okay? So make sure that you are the big church and not just focusing narrowly on the secondary care and the acute stuff. That certainly is one to look at. Thirdly, and there are 4 points, you have some specific cultural advantages in Africa, in Kenya. For example, the aspects of the community-based care, which are really big. And you've heard some speakers today, and you had speakers yesterday talking about the preeminence and the importance of community care. While that may be done informally in Africa, those are paying jobs in these other countries. So if there's a way to channel your talent into those jobs, that is an opportunity. And lastly, I would say that if you get that right, if you organize yourselves properly, you come up with the right recipe, why can't you be a role model for Africa? Why not start regionally in East African community? Because nobody from Africa is doing this. There is an opportunity for Kenya to be leaders here. Yes, it requires teamwork. Okay, success will only come as a result of teamwork. But if I look back to years past, you've got track and field, you've got rugby players, you know, Kenyans, when you work together as teams, you can be world champions. Thank you for your time.
Now, in the morning, I think there was a presentation we skipped due to the technical hitches, which was supposed to be presented by Dr. Fatuma Afe. The topic was challenges of healthcare workers in training, career paths, and progression in Kenya. Supposed to present online, and now she's coming up for the second time, hoping that this time round, yes? She's not online. So we move to the next. Yes. Then next is Gibore, what do you want to say? Let's look at the one who is supposed to present, and Oliver Baraza, Kenya Union of Medical Laboratory Officers Vice Chairperson. Is he around? Yes, can you give us some more guidance on this? Okay, I think I'm well guided now. I'll call upon the General Secretary, KUCO, to give 5 minutes presentation there after we go to panel discussion. Mr. Gibore, please. Five minutes, please. One is almost over.
Okay. Thank you very much, Ibrahim Wako, the Registrar, Kenya Clinical Officers Council. Once more, my name is George Gibore. I'm the General Secretary, Kenya Union of Clinical Officers. I will present on the engagement of health workers in the public service. I think this ought to have come before our discussion, but because now it's here, we'll just highlight a few. And yeah. I think we'll do the introduction, whereby we are saying that the healthcare workers is a cornerstone of achieving better health services. And at this era, the UHC, that is the universal health coverage. And according to the WHO, the healthcare workforce are all the individuals engaged in activities whose main focus, whose the main goal is to improve the health of its citizen. And this makes actually adequate staffing, appropriate skills, good attitude, and high moral of healthcare workforce to be the prodigal focus of an employer. So what I mean here is that for an employer to achieve where they, or rather to achieve universal health coverage, they must ensure enough staffing who are actually having the right skill. And of course, when I talk about the right skill, they must have the right mix of that skills. Because you can't have one of them, then you say you have enough. Then they must have attitude. We had already discussed about that. And of course, moral, where they are well motivated. Next slide. And of course, when you're growing as a country, you can't lack challenges. And some of these challenges is the cost of training, which is high for the healthcare workers. This also has a contribution to the cost of healthcare services. And I think we have been raising this issue. It needs to be looked into how it needs to be scaled down. Lack of uncoordinated HR management, policy gaps, lifestyle that leads to poor health, growing public expectation, rising costs of modern technology, driven intervention, and a complex clinical condition that demand effective multidisciplinary and multi-institutional working. So here we are saying that despite what is there, some of these challenges, we are requiring to work as a multidisciplinary with a clear focus where institutions are correctly linked or properly linked and well equipped for them to address the challenges that are coming on. In addition to these challenges, there is growing pressure on the healthcare system in the country to cut down and achieve better outcome with less resource. So what we mean that the cost of healthcare in our country is so high, we really need to look on how to bring it down. And it is attributed also on taxation on the health product, which is so high. So, and then again, that is an issue that we need to look at. And of course, you know, all of us that the health services is mostly devolved. And some of the challenges currently we experience is gaps in the policies, policy guideline, the management in management of the health workforce. Lack of coordination among governments, that is the county government and the national government. And that cannot be overemphasized because we normally have some of the county that do not want to comply to the national government policies where they claim autonomy, where they do not have any. And discriminative terms of employment, where we mean that you have people of the same qualification. Some of them are under contract with different names or rather title, but you want them to work toward a certain specific agenda. And specifically the healthcare workers. The cost of training, I think I've talked about that, go down. Healthcare workers strike, which has been attributed to lack of implementing agreements, especially the CBS, and even prolonged negotiations. Like for instance, I gave a good example, the negotiation for CBA for the nurses, which has taken more than 7 years, and the clinical officer, which is taking more than 4 years now. Inadequate management of in leadership and the leadership capacity in relation to human resource management. Inadequate and inequitable distribution of healthcare workforce. So we have a few years, but again, how do we distribute them to the counties is a big issue. Like when we talk about the specialists, if you get Nairobi, it is highly concentrated, but other counties, they do not have any. So how do we achieve that? I think we need to have a designed model where we can be able, even if we cannot employ more, but we have a way of sharing those resources, the human resource that we do have. I think that is crucial. Internal and external migration of healthcare workers. For instance, this is well known within our corridors. Lack of performance-based management system for human resource of health. For instance, the tools that we use to assess our healthcare workers does not actually project the services we are supposed to be doing. If you are given the performance contract, which you are supposed to actually fill in, the tool does not actually give you the purview on what you really need to achieve. And unfortunately, it's what I can call an outdated tools. I think people need to engage and get to see how to push a result out of your staff. And probably you normally say we represent only the workers, but also we want the workers to work, to work and perform. Next, and of course, insecurity in areas like Mandera. Last week, I think 2 weeks ago, you saw us saying one of us have been abducted by the Al-Shabaab, and this issue of insecurity is never looked into. Unfortunately, the health sector cannot do alone. So this is where we call on the security agents to ensure that our people who work in those areas are well protected. Go to the next slide. I'll not go through that. Okay, terms of employment. I think under our country, we have an act of parliament that provides for employment, specifically CAP 260. than the regulation of wages and the condition for employment. In this specific, when you look at section 7, 8, and 9, it clearly provides under what terms you can employ someone on what we call contractual term. And this is what probably as the representative of the healthcare workers, we normally find fault in the government, probably for muting these specific provisions. And of course, if you look at the terms of like what we have defined, I've clearly highlighted the definition of the employees and the contractual services. You look at what we're providing as an employee, it means that a person employed for wages or salary, and includes an apprentice and indentured learner. And to some extent, this is speaking to where we normally say that interns are not employees. So interns are clearly provided here, and we really need to get to understand that once you enter into an agreement, these people are well supposed to be represented. Go to the next. Okay, I think we have spoken about the number of counties which have resolved to engage healthcare workers in what we call contractual term. And this issue is demoralizing, and it has been the attributing factor for the numerous strike in our country. And of course, we are saying that for us to engage our healthcare workers, let us conform to the general and the specific principle in existing policies and legislation. Once that one happens, then you have got nothing that you're going against, and it attracts no reaction, especially from the representative. Next. I'm trying to rush this without more discussion. I think what I can only highlight from this slide is about the healthcare workers who probably have been forgotten. And as I gave the definition of the WHO on who is a healthcare worker, is everyone engaged in that term focusing on a certain specific probably achievement, or rather to improve healthcare. Now, when that comes, you always have made reference to our people who are existing within our setup. They are never recognized by an act of parliament. They do not have schemes of services. And even for those who have schemes of services have been muted. And also, they do not have specific name. They are never even remunerated, but they are expected to perform. So those are the issues that we need to speak to, and probably ask ourselves whether they are Kenyans, and do they need to be treated equally to the demand of this provision of the Employment Act. The next. Move to the next one, so that I know I have less time. So I think I don't know whether those numbers are projectable. I have just highlighted a few, but you'll see currently what we require and the current available staff and the gaps that we do have. If this is what we really lack, like for instance, currently we require consultants across 2,983. That is the projection of 2020. Then you have total number of 997. So the gaps become 23, 13. Let me jump to another, like the health records. We require 5,343, but what we have is 1893. We lack 40. So if you look at that proposition, then you wonder, how will we achieve that? How many years do we need to actually achieve what we are supposed to be having, looking at the gaps, because it is threefold. And let me look at the clinical officers, whereby probably we are saying they are supposed to be like the general practitioners. They are supposed to be 13,000 currently. I think this is the projection of 2018, but currently we have 6,355. We lack, by that projection, we lack 9,301. Look at the nurses. Again, for nurses, we need 38,197. And if you look what we have, 20,872. We are lacking 21,350. This is actually the trend across. And all the others, we have done the projection, it is others that down there. However, it's because I couldn't have them all on this projection. I think you look at, we want all of them which have not enlisted here. They are supposed to be 92,419. We have 37,284. We are lacking 72,395. And this is not my data. This is the government data. So I think my aspiration, or rather the aspiration of this presentation, we want to ask the government for them to move to where we want to be. We project to have annual hiring or deployment of adequate healthcare workers. This is prioritizing, like the way we normally do it for the discipline process. By the way, it can happen to the healthcare system, healthcare workers, so that we move closer to our projection, because that is not union position, it is the government position. Then a number of these issues that we normally have, like people having burnout, will not be there. And we will have equal distribution once you have the number of the staff you are projecting. So the other issue is building capacity for healthcare workers in all levels in the public sector. So I think I'll not speak to that. Establish a multidisciplinary team to provide comprehensive primary healthcare to a targeted population, so that we move from facility-based to probably what I can say household, so that we change the system from waiting to treat, but we move to prevention, where we do sensitization to household. To introduce multidisciplinary team led by family physician. Yeah, I'm done, thank you. Then I move to the next one. Yeah, I'll not read about everything, but this is very important that the scheme of service need to be in place and be implemented for all the cadres. Of course, payment of stipends for the community health volunteer. I deliberately use that word because I normally avoid, because they are still called volunteers. But I saw last year they were saying they want to train them. When you train them, they will demand. But of course, training is not the basic for employment, because under Employment Act, it actually anticipates a situation where you employ people who are not professional or even do not know how to read. So we want to encourage the government also to provide stipend for them across all the level. And of course, provide regulation for them. Thank you very much. And my clarion call is, let us implement the policy that we do have. Thank you.
Kenya Union of Clinical Officers. Now it is my humble pleasure to call upon Dr. Mercy Korir once more to take us through the panel discussion. But before I leave the podium, there was a request which came from Mandera, Abdikadir Khalif, who was intending to present on strengthening medical laboratory productivity. He has an abstract. He will be selected in the afternoon. So primarily this time we are going to give to the panel discussion. It's a very short time. Dr. Mercy Korir has alluded that she has only up to 1 p.m. So let me hand over the microphone to her. Thank you.
Thank you very much, Wak. Allow me to quickly welcome the next panel.